Hello and welcome to Implants A to Z from a restorative perspective. It's my goal over these next series of lectures to introduce you to implants or hopefully bring you to another level. I've been involved with implants at the restorative side for over 30 years. I was very fortunate, I believe, to be at UCLA when we began using implants in the early 1980s. And so I've had a research perspective, we've had an educational perspective, but I think most importantly to any lecture series, we've had a practical day-to-day use of dental implants in our office. We've used them in a private practice setting over this 30 years, and I think it has led us to certain really strong beliefs on what we need to do to be successful day in and day out on regular treatment of our patients. So the goal of Implants A to Z is really to bring all of us up to a level where we can be predictable, we can be successful, and to do that I think we need a philosophy. We need an understanding of the biologic perspective of what we're trying to do. We don't talk necessarily at a biological level, but we want to bring everyone to an understanding of what we can expect from a dental implant. When the restorative dentist knows what the future outcome will be dependent upon that placement of implant, I think they're better prepared to talk to the patient, to present treatment to the patient, and then get to a point that we can truly provide the service that is requested of us. So where did we come from? You know, there are certain cases I think that truly represent epiphanies in dentistry, and this is one for me that was shared with me from Dr. Jovanovic. This is a case where you look at this x-ray and as a dentist you realize there's no way we can save that tooth. Surprisingly, to a patient sometimes they're not even aware that there's a problem, internal resorption or whatever may be going on. So for them this is really a tragedy. And our ability, Dr. Jovanovic's ability to place an implant really years ago, immediately provisionalize the patient and then take that patient and over maybe a 6-month period be able to give them back a final restoration that I think any dentist couldn't pick out from the natural teeth surrounding it, I think is what is truly an exciting and really thing we want to do in restorative dentistry. We want to be able to give this to the patient in the easiest way possible. Now, in order to get to this level of treatment, I think it's useful to take a look back. Where did we begin? And really one of the first aesthetic porcelain emergence of a restoration I did in 1986. And this was a crown that was done really at that transition from where we expected to have titanium coming through the tissue to this realization that we could have porcelain coming out. So when this case was done in 1986, it was very exciting. For us as dentists, it was the first time that porcelain really emerged from the tissue. So when I was inserting this case for the patient, my excitement was enormous because the other option was to have titanium at least at the tissue level, and here we had something that looked pretty much like a tooth. But for me, I'll never forget that for the patient, when they took a look at this final restoration, they were upset. They didn't feel like it looked right. What was wrong with this case? What did we do inappropriately? And really that comes down to an understanding of the relationship of the position of the implant to the potential restoration. Still to this day, I would say the laboratory technique was spectacular. The intuitive ability to transition to making a direct connection restoration to the implant, that was superb using a UCLA abutment. But the placement of the implant limited the restorative potential. And I think that's something that we learned on that. So we start off by always thinking, where is the implant head so that we can produce the kind of outcome we want to have. The other things we needed to think about in that era was that we've lost more than just teeth. It isn't possible to do a restoration if we don't have the frame, the surrounding, the soft tissue to the restoration. So if we place an implant just because there's bone there, our ability to make a restoration that really looks good, that looks the way we want it to as a natural restoration, we're going to be limited restoratively. How do we manage the indentation labially of the soft tissue, the bone, the implant placed more lingually, palatally than we'd like it to be, the lack of interdental papilla? These are major factors that still confound restorative dentists unless they understand the limitations. What does produce the papilla between the teeth? Is it the implant or is it the bone on the adjacent teeth? And so we always look at the bone on the adjacent tooth. We have an expectation for the height of that papilla. And then on a case like this today, we would be presenting to the patient that they needed to restore not just the implant, but also the crown that's going on the teeth adjacent to it to close that space completely. But more importantly, it's a surgical understanding that to place the implant in a position like this, we will always have a modified restorative outcome. So how do we create this predictability that we want to have? As a restorative practice, a private practice, we can't afford really, when I hear people talk about an 80% success rate as some positive, I just shudder because there's no way in our practice we could survive if 1 out of 5 of our restorations was unacceptable. How do we create predictability? And we need to have the predictability we talk about it for dental implant restorations of 95, 98%. We can't afford these other problems. So we think about the position of the implant to the final restorative. We need to have an expectation that that implant is placed in a certain position, and what will that give us? So the communications with our surgeons will allow us to predict, and then we can discuss with the patients their individual potential outcome. It is, I think, a reasonable thing to understand what the predictability of the soft tissue is to the bone and that implant position. So our surgeons need to place the implant in a certain position, create the bone around it, and then it's almost expected where the soft tissue will develop around that. There are certain common sense issues that I think come up. When we extract a tooth, we think we want to fill that extraction site completely with an implant, and really is that intelligent? The bigger the implant, the stronger it might be, but we also lose biologic potential of the bones surrounding the implant. So it's a reasonable statement, I think, to say that the implant should be the smallest implant that can support the load. So our first goal is to select an implant that will support the load, and then we place that implant. We can develop restoratively from that point to have the correct emergence profile and emergence diameter. I rarely try to pick an implant that's wide diameter just because my central incisor might have a wider diameter. And what is the restorative value of provisionals? And I think this is an important concept because we carry over from conventional dentistry where a provisional on top of a prep crown is just expected. But a provisional on top of implants is very time-consuming. In fact, often at least as time-consuming as the final restoration. We need to make the provisional. It's very expensive, so from a laboratory point of view, there's costs involved, and so we tend to not do them. But there is an enormous value restoratively to provisionals, to guiding tissue development, to pushing tissue, to getting patient acceptance. So I think they need to be part of the treatment presentation from the beginning with the patient, and so they understand what we're trying to accomplish. I think it's also very important for the restorative dentist to understand what surgical options may be involved to improve the outcome. Too often as a restorative dentist, we send the patient back to the surgeon with a note, insufficient soft tissue. When we really need to manage that patient in our offices when we realize what the maximum potential might be and we may have reached it. And then the restorative options come into play. How can we solve the patient's problem? So over the next series of lectures, we're going to discuss the things we can do restoratively to take the case that may not have ideal soft tissue, to take ideal implant placement, and manage the patient in a way that solves that problem. The bottom line, I think, is that as a private practice, we want to be successful. We want to be successful with our implant patients. We want the practice to be successful. And for me, what I'm looking at is, from an implant point of view, I want an environment where all tissues, including the soft tissues, are stable. I enjoy reading articles, and I start off and I read an article and they talk about a 95% success rate, talking only about the implant. And then I look further down in the article and they're talking about a 10% creeping attachment. And what does that mean? If the soft tissue is changing continually, that is not successful. To me, that means there's not bone in that area. Something inappropriate is occurring. That's not the environment I want to have. And as I see the wonderful surgeons that we work with, their ability to create this stable environment leads to a situation where I can be very predictable and have the success I want to have. I think we all agree that we need healthy bone to be present to allow the development of the soft tissue to have that stability. So it's not just placing an implant, it's managing in a very delicate and successful way the bone and the soft tissue that surrounds the implant. Understanding, as we've discussed, placing the implant in the correct size and position will give us the most biologic potential for the bone surrounding the implant. If we place the implant in the correct apical position, it's almost guaranteed that we'll have the emergence profile we want to have. And that leads us ultimately to the success that we'll have in the patient's acceptance. I think if we understand as restorative dentists what our ultimate potential will be right from the beginning, and we can discuss that with the patient, and they understand what the limitations of their own case might be, we're able to achieve the result we want to have. And the patients ultimately appreciate that result, and that is what we're looking for. We are very critical by our nature. We look at every case, and I don't care how good it is. All the cases I'll show you over the next series of lectures. I always find something that we could have done better. But the key really is to present it to the patient in a way that they understand the challenge and the limitations. As restorative dentists, we know how hard it might be just to make the porcelain on an implant crown number 8 match the natural enamel on number 9. That can be incredibly difficult, and we put in the variables of soft tissue height, the implant position, color, shape. It becomes really difficult. So the patient has to be on board with the challenges that we face. The biologic basis, in other words, is that we need the implant to be in this ideal position. Now, we can do restorative things to make the case turn out better, but I think we need to have a goal. If we have that goal of getting the implant in this right position, we can almost always produce, in a very simple and predictable way, the outcome that we want to have. An outcome like this, using a ceramic crown, in really a very difficult case where Dr. Jovanovic had to take a failing implant, reconstruct the bone, reconstruct the soft tissue, place an implant in the correct position, but then restoratively, it becomes quite straightforward and simple. We just have to be able to do the restoration. And you see that emergence profile. But redoing an implant, I mean, a case like this might take more than a year compared to doing it in a few months if the implant is placed correctly from the beginning. So what are the fundamental principles that lead to an ideal outcome? I think this is something, as an introduction, we need to discuss. Does it really matter? Can we do different things? I hear lots of different points of view from restorative dentists, from surgical doctors. Everybody has a different idea, but I think that we can distill them down to some fairly basic principles. And we've thought a lot about this. This isn't something that just came out overnight. It's from 30 years of seeing very successful cases, seeing cases that became successful through a lot of hard work, and cases essentially that were failures. Understanding those 3 types of patients is what led us to really a strong understanding of where we want to be. One of the first cases that we did years ago, we didn't even really think of looking at the soft tissue. And now when a patient like this comes into our office, the first thing we do is evaluate the height of the soft tissue as the patient presents and get them a mirror so that they can see what they're bringing into the office. Because I hate to say it, but many times patients don't realize what they bring to you. In this case, if you hear the history, it's had an endo, it's had a repeated endo, it's had an apico, a repeated apico. She's lost tissue over 9 and 10, and she's losing tooth number 9 at this point. So we look at that. At this point, at this level of our understanding of dental implants, we didn't even think about emergence profile. We just thought about getting the tooth out and placing an implant. And the implant was placed. Fortunately, we had a lot of good bones surrounding it. We used a hex head implant. We did something fairly novel 20 plus years ago in that we used an all ceramic abutment and baked porcelain to it. And we ended up with the result that at the time was really very nice. And when we look back and evaluate it though, we noticed that the soft tissue stabilized about 2.5 millimeters above the placement of the implant. And what does that mean? What are we looking at? The other thing we notice is that the bone on the adjacent natural teeth define the height of the papilla. Just placing the implant doesn't cause soft tissue to grow. And so we identify the height of the bone on either side. We go to the final restoration and we notice, as expected, we have more soft tissue papilla. We see our emergence profile is about 2.5 millimeters above the head of the implant. This is all good. It's not ideal when I look at this case, but for that era, it was quite exciting and something that the patient truly appreciated because she didn't think she could have anything other than a bridge. One other thing that we notice when we look carefully at this case, and I think it's really important for restorative dentists to look at, is really the width of the restorative tooth. This case was provisionalized with a bonded restoration, and that bonded restoration can slowly widen the gap. No matter how careful you are removing a little bit of composite off either side, you might increase the diameter of the space. And so I think it's important for the restorative dentist to understand that and maybe discuss restoring adjacent teeth to keep the mesiodistal width of the restoration the same. But really the important take from this picture is that the ultimate emergence profile, without our really understanding it, ended up in a healthy situation being 2.5 millimeters above that position of the implant. Now let's look at the other extreme. Here an implant was placed. At that time a Sarah 1 abutment was used on top of that implant placement. And we look at maybe the ideal emergence profile, and we have what may seem like that perfect situation where we have excess tissue, but really it doesn't give us the aesthetic result we want to have. So if we assume 2.5 millimeters above that ideal point, and when we look at the implant position as it was placed, we realize that the implant was placed about 1 millimeter more coronal than we might consider ideal to give us that 2.5 millimeters of emergence. We also, and I think this is something we'll talk about more in the future, we placed an abutment for a cemented crown that was just barely below the level of the tissue, which is, I think, a very biologic way to do it. But should we have removed tissue first? I think so. We could have thought about that. We didn't really think about that. But here's another example where placing the implant gave us about 2.5 millimeters of soft tissue. Of course, again, the interdental papilla is based on the bone against the natural teeth adjacent to the implant placement. So Dr. Jovanovic and a group of really wonderful surgeons years ago looked at the position of the implant, and that totally supports and agrees with the ultimate emergence profile that we can expect from a very basic hex head implant, even without any additional surface technology, of about 2.5 millimeters. Now, if we're able to keep more tissue, more bone, what do we expect? An emergence profile that moves coronally. Can we remove some of that soft tissue? Perhaps. But it's not required, but I think these are the numbers that we want to think about. Common sense tells us if we sink the implant more apically, we'd be safer. But really what happens as we sink the implant apically, we're taking away bone, we're taking away biologic potential, and we're moving our emergence profile apically. And I've seen that with different surgeons over the years where they really believed it was better to be 3.5 millimeters apical, and then I see an emergence profile that's on average 1 millimeter more apical. And the crowns look longer. That is not acceptable really for me as a restorative dentist. So we're thinking more in these numbers. Now, of course, in today's world, we have implants. This is a Noble Active implant with a conical platform shifted interface. We expect to keep more bone, and indeed we do biologically. So it's almost common sense. If we keep more bone around the coronal aspect of our implant, we're going to keep more soft tissue. Our emergence profile might move more coronally. So it's almost like a contradiction, but to use an implant that keeps more bone, we almost need to sink it more apically, slightly, to give us the same emergence profile where we would expect to lose some bone. So on these implants, I can't say as a 100% rule, but we're thinking about their ideal emergence profile with healthy bones surrounding the coronal aspect of the implant might need to be 3 to 3.5 millimeters from the desired emergence profile. Let's take one more step to try to understand this whole concept, and let's really look at a biologic failure. This is an extreme consequence of non-ideal placement, and it really came about from the good intentions of a surgeon, from the common sense of a surgeon who thought they needed to do certain things to get a good outcome. From a restorative point of view, I think there's a glaring issue here of tunnel vision in terms of treatment planning the case that we'll review as we go through it. So what do we see when we look at this picture? This case was referred to me by one of my students because they've seen my lab. They think, oh, you can do anything. But is this a laboratory problem? Is this a technical issue? And the first thing I see is that the soft tissue is red and shiny. It implies there's no bone above this restoration, this lateral incisor. So I'm not so confident that this really is a technical issue, nor am I confident that pink porcelain would solve this patient's issue of this huge tooth that looks like it's coming, 2-3 millimeters apical from where it should be. The glaring issue from a treatment plan point of view is the retained deciduous canine that's next to this site. I realize the value of saving teeth, but as a restorative dentist and as a surgical dentist, we need to look at the teeth surrounding our implant sites and ask ourselves, what is appropriate? Should we be saving this tooth just to save it? And a retained deciduous canine in a wonderful position that seems to have beautiful bones surrounding it, to place an implant in the lateral site may not really be the most ideal way to manage the case. So we did decide to manage this case from a surgical point of view. One of the most difficult things is removing an implant that's been placed. I have a rule that if you want to guarantee integration of your implants, just put them in the wrong place. But we had to go into this case. My point of view with the surgeon was the one thing I didn't want to see happen was to have the papilla on the central incisor damaged. We wanted to do everything possible. So the flap technique, the removal technique of the implant, everything had to be involved with maintaining the bone on the natural tooth adjacent. So we can see just by laying the flap, we can see the damage that occurred by using a wide platform implant to replace a lateral incisor. So remember, one of my rules was we picked the implant based on force. Does a lateral incisor have high force? I would say no. Why was a wide platform implant picked? Because of the extraction site. I'm sure the surgeon saw that extraction site and felt they had to fill it. If you place the implant in an immediate situation, pressing against the labial plate, I like to think of the labial plate as the resorbable membrane, nature's resorbable membrane. Where does the circulation, where does the biologic support from the labial plate come from? Well, it comes from the periodontal membrane. Well, we've extracted the tooth. It comes from the subperiosteal membrane. We've laid a flap. There is no support to that membrane any longer. So if we press the implant against that labial plate, it's a guaranteed loss of that bone. So our goal is to keep at least 1 millimeter between the labial plate and the threads of the implant. So a narrower implant would have really been a more ideal way to go. Plus, this wide platform implant got very close to the central incisor, so that bone is in jeopardy. At this point, I think the surgeon has to make a real decision. Do they trephine out this implant and really the creation of a very big defect? More ideally, I think the surgeon was able to use piezo knives, removed a little bit of bone labially, pop the implant out, graft the site. We could wait and come back and place an implant into the site, but remember we have a retained deciduous canine next door. So we'll remove that canine and place the implant into that very nice site with the plan to cantilever the lateral into the ponic site. This is a perfect case, a perfect example of using a provisional to help guide the growth of the soft tissue from a restorative point of view, to evaluate it and see what we can accomplish. When I look back on this case done many years ago, I see a provisional that I really had the wrong concept. I was trying to make the most aesthetic provisional, and really I want to use the provisional as a, if I could say, orthopedic device to help guide the soft tissue, to help guide the growth of everything. So I should have created a little bit more of a diastema between the central incisor and the pontic to allow the soft tissue to develop. I should have created a little bit bigger diastema between, gingival diastema between the pontic and the canine provisional to allow the tissue to develop. I've learned that you can push that pontic within 1 millimeter of the bone at its central ovate position to create a nice ovate pontic, and will create more soft tissue that way. I wait between really 4 and 6 months to allow the tissue to develop, take another impression, and make a final crown. So in a case like this, of course, the better way to manage this case would have been to recognize the minimal amount of bone, not to use a large diameter implant, maybe the extraction of the deciduous canine right from the beginning, placing an implant in a more ideal position, but being able to do these things to restore them, doing some veneers on the central, we've certainly improved the situation. Is it perfect? No. So that's why we like to look at the initial implant placement and try to guide things so that we get accomplished what we want to have. I look back at certain pioneers in implant dentistry, Dennis Tarnow being one of my favorites, And he looked at soft tissue. And so one of the things that we really consider is what is our potential of soft tissue? And just looking at natural teeth, without any skill as a surgeon, we can expect 100% of the time between natural teeth that we'll get a soft tissue papilla of 5 millimeters. When we have an implant mixed into that, we think maybe 4 millimeters. So if I have good healthy bone on the natural tooth, I place the implant so that it doesn't impinge that bone, meaning about 2 millimeters away from the natural tooth, we will maintain a papilla of about 4 millimeter height. And this helps me treatment plan the case so I can give the patient a predictability of what I can accomplish. If I realize there's going to be a deficiency in an area, then we look at crown lengthening, we look at restorations on adjacent teeth, if that's the result the patient wants to have. The other thing I think we need to accept, and there's too much emphasis on, I can restore that case in a week, I can restore that case in 2 weeks, I can restore the case in an hour. Those things are fine if we understand what the gingival changes will be. The gingiva does change depending on the amount of trauma that's accorded to the bone that's surrounding the implant, the bone grafts, the soft tissue grafts. We expect when the implant is placed and the tissue is covered over the implant and then the implant is exposed, that soft tissue is going to change for at least 6 months after the implant is exposed. If we have a healing abutment on as a one-stage procedure right from the beginning, well, the tissue is going to be a little bit more stable, but it's going to be healed down to the diameter of the healing abutment, so we'll see changes over the diameter of the provisional or the final restoration, again over probably 3 to 5 months. So there's changes in that soft tissue. If you're planning to do a cemented crown, understanding where that margin needs to be is critical to the outcome. And so rushing ahead and just assuming that the tissue will be fine and just sticking the margins subgingivally will lead to many problems. So our goals, what are our goals? First off, understanding what the patient's limitations might be, understanding what the surgical limitations might be, doing everything possible to manage those limitations, presenting it to the patient in a way they can accept. We're very careful with the words we use. We don't even say implant if we can avoid it. We like to say replacement root. We don't say surgery, we say procedures. But there's times I want the patient to know what their challenges are. I want them to know that they have a bony defect, they have a soft tissue defect, that the very skilled surgeon will make every attempt to reconstruct, but our ability to do 100% reconstruction of a papilla or even a labial development of the final restoration may be limited. But we need to have options. How can we manage that? The size of the defect, of course, impacts what we're trying to accomplish. So these things need to be involved in the treatment with the patient. I want to sit down and just tell the patient, don't worry, everything's going to be great, but it may not be. And I think presenting that during treatment planning, making them understand what their challenges are, makes them accept the final treatment in a much more reasonable way. Surgical guides is one of the things we'll talk a bit about. And I think it's important not only to help guide the surgeon, to show the surgeon what we want to achieve as restorative dentists, it also helps show the patient. If you put in a surgical guide with the ideal shaped teeth and they see this huge soft tissue defect, I think it might emphasize to them what the challenges are. They're more amenable to going through repeat surgical treatments if that's the goal they want to have. And so I explain that. There's times we have a low lip line. They don't show the area. There's nothing wrong with having teeth that would be a bit longer than we would like to see. But they need to be part of that treatment because if they lift up their lip when we're all done and we realize that they're not satisfied with that outcome, then it's a problem. So the surgical guides, I think, help communicate to the surgeon what we're trying to accomplish, but also helps communicate to the patient. One of the rules we'll approach more dramatically as we go through this is implant proximity. My greatest aesthetic challenges in the anterior segment have almost always been related to implants placed too close to each other or perhaps to the adjacent natural tooth. When the implants get closer really than 4 millimeters, we begin to have challenges. We get a negative papilla or at least a flat papilla between the implants. Making that look good unilaterally is extremely challenging. When the implant gets closer than 2 millimeters to the natural tooth, we start to have an impact on the natural bone leading to the papilla between the implant and the natural tooth. So planning out the case, understanding these biologic limitations, I think is critical to getting the outcome we want to have. So how do we get this natural, non-detectable tooth replacement? I think that should be our goal. It is not required on every case, depending on our ability to communicate the limitations to the patient. We're thinking about the head of the implant. Just in general, about 2.5 millimeters apical to the desired emergence profile. As we use implants that tend to keep more bone, maybe going a little deeper, maybe 3. It just really depends on the surgeon's experience and their feeling for that given case. The position of the implant buccolingually is also critical. As the implant is placed too far palatally, that usually is the result of a lack of bone on the buccal. So we have that concave look that never looks good restoratively. So we need to develop the bone buccally to bring the implant into the right position. As we move the implant too far labially, then we have a tremendous problem, a lack of biologic support. As we press on the labial plate, we'll tend to lose bone, we'll tend to lose soft tissue, and then we have a tremendous problem. So there truly is that ideal position, which is about 2 millimeters lingual to the desired emergence profile. When we do that, we just have that beautiful mix of aesthetics and biologic potential that give us the restorative result we want to have. One of the biggest challenges is fitting the implants between natural teeth. As a surgeon, I know they're incredibly pressured to thread an implant in. It's a 6 millimeter gap, use a 3.5 millimeter diameter implant, you can do it. Well, it gets challenging. And just the slightest 0.5 millimeter drift towards a natural tooth could really challenge that case to becoming an ultimate failure, and the lack of bone on the adjacent natural tooth, which to me is a tremendous loss. So we need to be intelligent. What is the limitations? When do we look at the patient and say, we can consider this if we do orthodontics to idealize the interdental space? When do we as restorative dentists say, we don't want to do an implant here. We have conventional dentistry that is more predictable and more conservative than placing an implant in a way that might destroy bone or damage the adjacent natural tooth. So there's limits, and I think we all have to respect them. In our treatment planning, we need to think about how much space do we need between our implants. It's so common the first implant goes in and we have about 2.5 millimeters to the natural tooth, and then the surgeon realizes to fit the next implant in, they're going to be less than 1 to the natural tooth on the opposite side and less than 2 to the implant. That's impossible. We need to think about the whole case, and when we get into those situations, I have so much respect for the surgeons that say, the implant is wrong. I'm going to take it out, we're going to come back another day, and we're going to do it correctly. And we're going to look at some cases that have that challenge. As restorative dentists, we also need to communicate to the surgeon what the sufficient clearance needs to be to the opposing occlusion. What kind of abutment do we want to use? Do we want a cemented restoration? Do we want a screw-retained restoration? All those things will impact how the implant is ultimately placed. If we have a lack of interocclusal space, and the implant might need to be placed a little bit deeper than we might like aesthetically because we need it for restorative space, then we need to communicate to the patient what that reality will provide. The one thing I've learned, I guess the one thing I'm the proudest of as a restorative dentist is that I realized early on if I worked with a great surgeon, if I had a great lab, I look good. And I think that's the truth for all of us. It's a lot of pressure as a restorative dentist. You get a lab bill that's more than what you quoted the patient, that's a very bad day. We need to understand what the costs are from the laboratory. We need to communicate well with our surgeon to create the result that we want to see. And if we can do those two things and base our fees really on the costs of providing that service, I think we're very satisfied, the patient is satisfied. They need to be educated that there's different types of restorations, different types of implant placement, different types of outcomes. Mini implants, well, that's great if you can accept a 25% failure rate. I can't, so I don't use those as final restorations. So people need to look at these things and communicate honestly with the patient. We can't lump everything together, and the patient needs to understand those factors. So what are we looking for a natural reconstruction? We want positive bone volume in really every dimension, horizontal and vertical. Vertical to get the head of the implant in the right position, horizontal to have the correct emergence profile and shape, so the soft tissue gives the frame to the restoration that we want to see. A great surgeon looks at not just mesial distal placement, buccolingual placement, apical coronal placement, and even angulation of the ultimate implant. All those things together produce the most aesthetic outcome. When we have healthy, stable bones surrounding our implant in the right position, it's almost guaranteed that we will get the right soft tissue outcome. And that's what I'm looking for, and that it's stable. So that aesthetic soft tissue contour, often we begin with excess tissue. Sometimes the surgeon might go in and recontour it a little bit, but often just placing the crown in the right position, the tissue reorganizes and it looks spectacular. Subgingival emergence profile comes from placing the implant in the right position. If we place it too far apically, we just move the emergence apically. If we place the implant too far labially, we also lose apical tissue because we lose biology. So the correct subgingival emergence profile comes about from the correct implant positioning. Then we turn to our lab, aesthetic contour, shape, and color of the restoration. Sometimes the restorative dentist assists in this regard by providing a provisional, by shaping that provisional intraorally through a progressive shaping of that provisional over maybe a 6-month period of time. So we create this ideal restoration. It may not be the correct material, it's acrylic, it may not be the correct color, but when we correct the beautiful soft tissue shape, and we have an idealized shape of the restoration, we can communicate that to the laboratory in a way that they can provide this outstanding final restoration. Where does patient acceptance come from? Surprisingly, I've had cases referred to me that were spectacular and the patient's unhappy. And they've come to me so that I could, criticize this other dentist. And you have to look them in the eye and say, this is a spectacular outcome. And they're unhappy. They're unhappy because they didn't understand the challenges. They might be unhappy just because they got the final bill. So we need to start developing patient acceptance from the first day they walk into the office, identifying what their challenges are, explaining how you'll manage them, explaining what the odds of success are, explaining what the challenges that might occur, their willingness to have additional procedures done. When they understand those challenges, when they understand what you're up against, just matching porcelain to enamel might be, I believe that they're more willing to accept the final restoration, or at least be part of the treatment in a way that they can give positive input before they become upset. So we work very hard at achieving patient acceptance from the very first day the patient walks into the office. We believe in a team management. So again, I look for these great surgeons, I look for great laboratory technique, but the team also occurs in our own office. We want to be able to talk to the patient. We would like our staff to be able to support what we're talking about to the patient. The last thing I want to have is a new assistant to walk in the room and say, oh yeah, he's going to screw some implants into your bone, and the patient just freaks out. So we need our entire staff really to have an understanding, at least to the point of view of, that's a good question, I'm going to have the doctor come back in and explain that to you. Communication is critical between the restorative office and the surgeon. Of course, I feel that the best surgeons understand the restorative side, just like I feel the best restorative dentists understand the surgical challenges. Just notes of, evaluate for implants and sending it off to the surgeon will not produce the result or the team effect we want to have. What's the patient's goals? What do you feel the challenges are? What are you trying to accomplish? Fixed, removable, porcelain, hybrid. All those things are important. Working with other specialists like orthodontists, endodontists to maintain teeth or move teeth into the right position. Communicating with our lab, but also listening to what they understand as the challenge to the case. Maybe the color, the position, the emergence profile, the strength of the restoration. I don't want to put a restoration in the mouth that, 6 months later is starting to break apart and I have issues. So all of us have to work together, and I feel like when we do that, we get these fantastic results that we can be proud of. Of course, every one of our cases involves trying to create ideal implant placement. So if we have that in our mind, what this case will need to have that ideal placement, I think gives us a goal. Do we need it on every case? Thankfully, no. But at least if we have these challenges, we can talk to the patient about it. We have a reason why we might have a certain result. And I believe we can be predictable. We should be predictable for the patient so they know what's coming. Over the last 10 years, probably, I've been excited about immediate placement with provisionalization, maintaining and conserving bone and soft tissue. Of course, this is done on cases where we like the soft tissue profile. We like the aesthetics the patient has now. Maybe just if we don't like the color of the tooth or the restoration, we can improve that. If we don't like things, then we really shouldn't be thinking about immediate restoration unless that's appropriate. We realize that these cases are very technique sensitive, that are very experiential. The more experience the surgeon has, the more experience the restorative has, the better these outcomes are. We also have to be prepared as the restorative dentist that we can't do an immediate provisional. What are we going to do instead? How do we maintain the patient? One of our bywords in our office is taking care of the patient. How do we take care of them? We don't want them feeling like they're going to have to walk around without a tooth for 6 months just because we couldn't do an immediate provisional. How do we take care of them? And then as restorative dentists, as being part of the team with our surgeon, when I say non-ideal implant placement, it doesn't mean they did something wrong. Maybe this was something predicted. How do we manage it? How do we make it turn out better than it might be? Does it require several provisionals? Does it require restoring adjacent teeth? Does it require crown lengthening on adjacent teeth? It may require all those things, and if we haven't discussed that with the patient before we began the treatment, then it looks like somebody made a mistake. And if someone's made a mistake, it looks bad to the patient. The patient will never be happy. They'll never be satisfied. They'll never think of it as a success, even though you might, because you understand how truly challenging that case was. You know, when I analyze restorative dentistry, especially restorative implant dentistry, the biggest change in our office was the realization that if we could make an accurate, predictable impression that was always right on, even if I was doing individual crowns, if I have interproximal contacts that just go right into the mouth with no adjustment, my life is easier. So one of the most important parts of this lecture series, if you had to do just one part, it would be how to take an impression. And it isn't just putting on some plastic copings and closing your eyes and having your assistant pop an impression. That will not give you the predictability you want to have. That changed our office from, oh my God, it's an implant patient coming in, to, oh God, thank you, it's an implant patient coming in. We're excited to have them come into the office. And I mean everything from a 2-implant case to a full arch implant case. It makes life predictable and successful. If you could do a full arch of prepped natural teeth in the amount of time I can do a full arch implants, I would be surprised. And with the accuracy that we have, there's really unknowns. Did I miss a margin? No, everything is there. For me as a restorative dentist, the challenge, even now, I forget on some cases, is provisionalization. It may, I realize I got to do a second provisional. I have to alter the provisional. I have to play with it. That's a lot of time consumption. It may not have a direct laboratory cost at that level, but I might be spending hours with the patient to get the result I want to have. So on the aesthetic cases, I strongly recommend that you look at the aesthetic provisionals you might need to create. And it may be multiple. It may be a lot of time. It may be lab issues. So you have to plan for it. For the posterior cases, if the patient's been without teeth for 6 months a year, I'm not going to worry about it too much. But if they need that area to chew, we may think about how we could sequence a case, use provisionals to get the case to the point that we can actually do the final restorations. But I guess the other really most important issue that I see in restorative dentistry is the needs to effectively communicate both the limitations and the advantages of treatment while you educate the patient. You need to be able to talk to the patient. The hardest thing is to talk about limitations. The hardest thing is to talk about challenges. But I think you need to talk about them. Patients have a way to shut you down. They cross their arms, they look away. They don't want you to really tell them those things. But that's what you need to do. And sometimes I grab their face and turn it towards me and say, this is the challenge that we face. But I'll be with you the entire time. I will take care of you over this next 6 months. And but for a day or two, or maybe an hour or two here or there, you will have teeth and you will have your normal lifespan. You'll do everything you want. You will do the things you want during that period.
For more education programs, visit the Guide Institute at www.guidedental.com.